So tell me what attracted you to medicine as a career.
I thought a lot about that, and I think my dad was a physician. He was an internist in sole practice in New London, Connecticut. Um, and he used to make a lot of house calls. And I used to go with him. And I sort of started remembering when I was about 7 or 8 years old that on some of these trips that we would make, of course, I wouldn't go into the house. I'd stay in the car when he went in to try and find the street number. He, when it got to be dark, would turn on a spotlight that was on the driver's side to find the house number. And I remember how cool that was. And that seemed to be a tool that physicians used. And I could do that. That would be something that I could be interested in.
How old were you then?
I was, I think, 7 or 8 years old.
Yeah. And when was this?
This was, so I was born in 1942. So this was sort of the end of the 40s and the beginning of the 50s.
So this was also an era when they were just developing the use of antibiotics. There were just medicine was really undergoing a transition.
True.
And you were growing up there, and your dad was practicing.
Yeah. I also remembered that, obviously based upon no good evidence at all, that if you got sick, no matter what organ was involved, that you'd get an enema. And I thought a lot about that also. And I thought that there were 2 tools that a doctor could use. They could use a spotlight. And since it was always better to give than receive an enema, that as long as I wasn't getting them and I could give them, that was another reason why I thought about being a doctor. My father was very influential in, I think, me making my decision to want to go into medicine. We had a huge house, and he converted the entire first floor to his office and the waiting room. And there was a very long stairway. And of course, if we had HIPAA laws in those days, I would have broken every one of them. But I would remember sitting on the stairway and listening to his interactions with patients and how very much they respected him, appreciated what he did.
Sure.
And, I, also thought that spotlight, giving enemas, getting respect.
It's as good as it gets.
It sounds like something I would want to be.
Okay. And so you went to college eventually. Where did you go to college? What did you major in?
Yeah, so I went to Tufts College, and then I went to Tufts Medical School. And then I did my internship and residency at the Tufts New England Medical Center. It's interesting that my dad had gone to Tufts College. My dad went to Tufts Medical School. And so it seemed like I was just following in his steps. One of the things that we were missing at the Tufts New England Medical Center was a really good program in pulmonary. So in those days, I mean, so this was around 1968, 69. The only ventilators that we had was a control ventilator, and there was no assist control, and then there were IPPB machines. And I really felt that, this was something that was missing in my training. And while I wanted to be a cardiologist, that I would try and distinguish myself from other cardiologists by actually doing a couple of years in a pulmonary fellowship. And I ended up applying to a number of programs, wanting to go to the Cardiovascular Research Institute in San Francisco, where Julius Comro was, and applied to a few other places, asked for applications at a few other places. And after hearing from the Cardiovascular Research Institute that they wanted me to take another year of residency, and I didn't want to do that, I wanted to go off and do subspecialty training, I decided, well, I'm going to forget the pulmonary thing and I'm going to apply for a cardiology fellowship. Now, here's a number of things that I would never advise anybody to do. I applied to one cardiology program because my mentor said, you will get in anywhere you want. We will help you do that. Where do you want to go? And I said that I wanted to go to Emory, where Hearst was. And in those days, that was, if not the best cardiology training program, it was one of the best. J. Willis Hearst had a reputation of not being one of the most pleasant individuals, but I figured that I could handle that. I had an interview scheduled. I showed up, and they had no record of me being scheduled to be there. And so I remember Hearst coming out of his office and hearing from his administrative assistant that I was there for an interview. And he looked at me and said, well, you're not on the schedule. I don't have time. You'll have to come back another time. At which point I said, gee, I already spent this money and I really don't know if I'm going to have another time. And he said, oh, all right, come with me. In those days, they actually televised their medical grand rounds throughout a number of hospitals in the state of Georgia.
Wow.
So I was sitting in the front row with Hearst, and I got my charcoal gray suit on, and this is really towards the end of my internship. And medical grand rounds was given by the chief of gastroenterology at Emory. And his idea of medical grand rounds was to pimp the audience for about 45 minutes. Nobody knew any answers to any of his questions. And then he sees me in the front row and he starts picking on me. And as luck would have it, he asked me 3 questions. I know all 3 of the answers, at which point Hearst thinks that I should be interviewed. So they wined and dined me for the rest of the time that I was there. He said, you'll hear from me in 2 weeks. I don't hear from him in 2 weeks. I don't hear from him in 2 months. The end of the next year is actually fast approaching. I actually got a full, it was called a Berry plan in those days, a full Berry deferment to finish all of my training in a subspecialty before I had to go in and fight the Vietnam War. And so I didn't have a training program to go into. I remember it was like a February, it was snowing, and I got a call. It was about 4 or 5 o'clock in the afternoon, and it's Hearst. And he introduces himself and he says that I'm making my calls. I don't have much time. You've been selected to come down here to do a senior residency. He said, but I don't want to do a senior residency. I want to do a cardiology fellowship. And you probably have forgotten that you were going to call me months ago and tell me that I got it.
Right.
And he said, well, if you come down here and do a good job, then you'll become a cardiology fellow. And I said, I don't want to do that. He said, so you're turning me down? And I said, yes. He said, okay, then I'm going to offer you a cardiology fellowship. So I said, I'm really confused. Can I call you back tomorrow? I need to have a conversation with my wife. And he said, no. Now you have to give me an answer. He said, well, if I have to give you an answer, I don't think I want to come down and train with you. So we hung up the phone. And for the next 2 weeks, I'm thinking I have to call the Defense Department. I have to go into the service. Dictating a chart. I remember these times really well. It was 10:30 in the morning. I'm in the record room. It's a sunny day out, and I get a call. I get paged, and it turned out to be Harry Fritz at Columbia Presbyterian Hospital. And so he was the chief of the pulmonary service there. He said that we didn't fill our pulmonary fellowship program. It's an NIH program. We have one slot left. I noticed that you had asked for an application, but you never sent us anything back. Do you have anything to do next year? And I said, no. He said, well, do you want to be a pulmonary fellow? And I said, I don't know. And so he said, well, I'm about to leave. I'm going to go on vacation. If you want to be a pulmonary fellow, call Chris, my administrative assistant, show up August 1st, and you'll be a pulmonary fellow. And so I obviously decided that I should do that rather than to go to Vietnam. And that's my story as to how I became a pulmonary physician.
That's a really interesting story. Now let me back you up a little bit. What years were you an undergrad at Tufts?
60 to 64.
Okay.
That's undergrad, yes.
And then med school was 64, 68.
Correct.
Okay. So you're coming out of medical school just as the riots and everything else were starting with regard to Vietnam protests and other things. It was probably just getting underway around then.
Correct.
And you moved into your pulmonary fellowship. Now, during your residency or your medical school, I'm sorry, how was life? Was it? I mean, I hear you were married. How was life when you were a student?
So Ludmerer wrote a history of medical education.
Yes, Time to Heal.
Time to Heal. And in that book, they talk about our class. As first-year students, we had an 8-hour biochemistry final.
Mm-hmm.
4 hours the day before Thanksgiving, 4 hours the day after Thanksgiving.
Mm-hmm.
We never forgave them for that.
Mm-hmm.
I mean, during these times, I think medical education was, I would say, probably bordered on brutal at times.
Mm-hmm.
And certainly at Tufts, I think things have obviously, much improved. It worked very, very hard. I carried over to the internship and residencies during those days also, where I remember doing 24 months, so the internship in the first year of residency, being on every other night, every other weekend for 2 years. And that's why during those days, the internal medicine training was so intense that if you weren't going to be an internist and you were going to do subspecialty training, that after those 24 months, the feeling was that you were ready to go ahead if you were going to do subspecialty training.
Mm-hmm. It was that intense. And with regard to, sleep deprivation, stress levels, difficulty with just, maintaining a married life?
Horrendous. So yeah. I remember as an intern, so 1968, there was the Hong Kong flu pandemic.
Yeah.
And many of my fellow interns actually got the flu and were out. And I actually was on and not expected to sleep for 3 straight days. And at the end of that, it was about 11 o'clock at night. I remember taking care of a patient in the ICU. Her first name was Stella. And I remember calling my first-year resident who was sleeping, saying that I couldn't function anymore, and that I was going home. Mm-hmm. He bolted out of bed, said, "You can't do that. You'll be AWOL. You'll be, flushed out of the program." And I left the ICU and walked to another part of, it actually was the Pratt Diagnostic building at that time, and went to the GI floor where I had my bag. And as I'm about to walk out of the hospital, I go by a large room that had probably about 6 or 7 patients in it. And one of the monitors was going off, and the person was in a VFib arrest. And I remember calling a code, and I remember taking care of that. And I don't remember much more after that. They couldn't find me for 36 hours. Mm-hmm. And they thought that, they called the police, they thought that actually I had left. Mm-hmm. Right across the hall from that ward was where the nurses would give patients baths. And one of the nurses opened up the door and found me. She thought I was dead. I was sound asleep in the tub with all of my clothes on, and she screams and wakes me up. Uh-huh. And I think that, you know, the work hour shifts now make a lot of sense when I think back to that particular experience. But the work hours were really quite brutal.
So there was the physical stress of the entire thing, the sleep deprivation and the like. What about relations with attendings and things like that? Were they civil? Were they, was there a lot of pressure?
So a lot of pressure, and it's interesting that you should, remind me of that. Hadn't thought about this experience in a long time. Christmas Eve of my internship, within a matter of 45 minutes, I had 3 young leukemics die. Mm-hmm. And the next morning, Christmas Day, the entire hematology service was there. We're sitting around a table, and they, wanted me to relate what happened to all 3 of the patients. And I was so upset about it that I just said, they died. Mm-hmm. And I actually remember just getting up and leaving the room. Mm-hmm. And so it was not a gentle time. The training was brutal, physically and emotionally. Sure, that was a common experience. And with regard to during your residency and fellowship, the treatments that you used, the common diseases that you saw, how would you describe that? So the blood gas machine had just become available in 1967. So I'm an intern in 1968. Pulmonary embolism was a rare event. And the Dexter lab and Jim Dolan at the Brigham were just starting to actually report on doing pulmonary arteriograms. I remember if we thought that there was a pulmonary embolus, we didn't have a scintillation scan to do lung scanning, at the Tufts New England Medical Center. And so we used to put patients in cabs and send them to BU to be able to get that study. If we needed to give an IV diuretic, it was intramuscular mercurhydrin. Mm-hmm. Ethacrynic acid came out towards the end of my internship, beginning of the residency. Lasix came maybe a little bit after that. If you had gram-negative sepsis, the only antibiotics that you had were really, for gram-negative sepsis, you'd be giving IV colistin. Mm-hmm. And so none of the aminoglycosides, had been invented at that time.
Chloramphenicol?
Pardon?
Chloramphenicol?
Yeah, well, chloramphenicol, yes, that was obviously a mainstay of treatment. And then during those days, if you were having a heart attack and you ended up giving nitroglycerin, somebody actually got thrown out of the training program on the Tufts service at BU for actually giving nitroglycerin to an MI who was having pain.
Because?
It's a much different time.
And they got thrown up because why?
Because it was contraindicated to actually do that.
Okay, all right. I'm a gynecologist, so.
Yeah, because you could drop somebody's blood pressure and kill them.
Okay, all right. And with regard to treatment, now you were in pulmonary, so with regard to pulmonary diseases, talk to me about asthma in those days.
So during my fellowship, so asthma in those days, I think that it was controversial whether you'd be giving, well, first of all, the first inhaled medicine other than a bronchodilator turned out to be cromolyn. Mm-hmm. It was a big stir about that. I mean, it took probably another 5 years before there was an appreciation that this isn't just a bronchospastic disease. This is an inflammatory disease of the bronchial tubes. Mm-hmm. A lot of parenteral epinephrine, adrenaline that you'd be giving somebody. We did have steroids to end up giving. Mm-hmm. But again, the inhaled medications and thinking of asthma as an inflammatory disease was quite novel at that time.
Right. That was probably late 70s, early 80s, that sort of thinking was moving in?
Yes.
Yeah.
Yeah.
And with regard to TB, did that have much of a presence during your fellowship?
Well, at B, so if you were at Boston City Hospital, the answer would be yes. At the Tufts and Lincoln Medical Center, I think we weren't seeing a lot of the cavitary disease, but I think, it would be fever, of unknown origin, where you'd be spending your time looking at that. But again, inner city patients, they'd be more likely to end up at Boston City Hospital.
In chronic obstructive pulmonary disease, what sort of treatments and the like were you experiencing then?
Yeah, I think in those days, you'd be giving, again, the bronchodilators. Aminophylline would be a mainstay of treatment. That would be a mainstay of treatment for somebody who needed IV therapy with asthma, that ended up coming into the hospital.
Right. And good. So that gives a sense as to the scope of some of the more common conditions. So you finished your residency and you finished your fellowship. And what next?
So I finished my fellowship, and then one day I get called down. So this is at Columbia by the chief resident in radiology, who I was friendly with, and he said, I have an interesting X-ray to show you. And so we're looking at the X-ray, and he said, so what do you think? And I said, well, bilateral hyaluradenopathy, a right paratracheal node, probably sarcoid. And he said, so who are you going to see to work you up? Uh-huh. So I'm actually now getting ready to go into the service. So, I end up getting a chest X-ray, EKGs, I get a variety of other things. In those days, the Siltzbach-Kvine test, which was taking a suspension of spleen made by Nelson, who was the dermatologist, and Siltzbach, who was a pulmonologist, was still available. Turned out to be the only Kvine test that actually, had really good testing characteristics. And so rather than having a mediastinoscopy, because transbronchoscopic lung biopsies, were not heard of yet, and I ended up having an injection in my forearm, and I actually still have the spot there. And 6 weeks later, I all of a sudden had this thing growing on my arm, and it was biopsied, and non-casein granulomas, popped up. And it was interesting that, so I ran a subacute course, which goes the time you're diagnosed and within and up to 2 years, if it disappears, that's the subacute course. Chronic disease is, more than 2 years and could be a period of time. And so Nelson was the one who did the biopsy. Silsback had actually migrated over to Mount Sinai. And I said, so how do I know when the disease is going to be quiescent? And he said, well, all of a sudden, you'll just be left with a scar and there won't be a growth there anymore. And lo and behold, about 6 months later, the thing disappeared, and nothing has regrown since then.
Lucked out.
And
wow.
So
now we're in the mid-'70s, right?
That was the early 1970s. So then I went to fought the Vietnam War in Biloxi, Mississippi, in the Air Force.
Okay.
I was there from 72 to 74.
Okay.
And then wanted to end up having a career in academic medicine. Applied for a variety of places, and ended up at Brown University in the Rhode Island Hospital, where I was from 74 to the end of 78.
So let me just back you up a little bit here, because up until now, well, up until a few years before, you followed in your father's footsteps. So at some point you decided, I don't want to be driving down the street with a spotlight anymore. I want to go into academic medicine. What sort of moved you in that direction?
I think it was the people who I looked up to as mentors, not necessarily from a patient-focused care standpoint, because patients were obviously treated in a very passive way, in those days. But I was really impressed by Louis Weinstein in infectious disease, Robert Schwartz in immunology, William Schwartz in kidney disease, and Crosby in hematology. And I wanted to follow that path. Yeah.
No, I think it's really interesting to me, just the role that mentors play in careers for everyone. And so I was glad to hear that. So you were Brown, and there for roughly 4 years or so. And then, is that when you came to UMass, or?
I forgot his first name. Budnitz, who was
yes.
Great man. He was the chairman of the Department of Medicine at Worcester City Hospital. When I was at Brown, his son, Albie, was one of our pulmonary fellows. And Albie told his dad, when his dad was looking for a grand round speaker, that, you should ask Richard Irwin to give a talk, because he's really getting into this cough thing. And, I think you'll be pleased with, the talk that he gives. So I ended up giving medical grand rounds at Worcester City Hospital. Jim Dolan, who had now become the chairman of medicine here at UMass, and he was looking for the chief of pulmonary disease. So Dr. Budnitz actually said, you probably ought to speak to this Irwin guy. So Jim called me and took me 8 trips to make the decision. But I came here January of 1979.
Excellent. So those were interesting days at UMass. Talk a little bit about UMass in its early days, because it was a very different institution than it is today.
It was very different. So I consider myself as sort of like the second wave that came in.
Right.
So the first wave, the medical school graduated its first class in 1970. The buildings hadn't been built. The medical school building was completed in 1974. The medical center, the University Hospital, was completed in 76. And so Jim Dolan, I think, came out around 76, or maybe a little bit before that. And when I arrived here and got my office and started seeing patients, the inpatient census was 33. Sleep apnea had just been described, and I remember, patient had basically right heart failure, and I remember Dr. Dolan saying, why don't we let the new guy come and see the patient, looks like he's having trouble breathing. What they weren't aware of is that, the person appeared to be Pickwickian and had right heart failure, but the major issue was severe obstructive sleep apnea. So, he was thankful that all of a sudden, they had a pulmonary person here. The thing that I remember is that every year there was a discussion that we need to close the medical center because we had other really good hospitals here, especially at St. Vincent's. There was always, the huge issue with the legislature would then be in a position to actually pull funding away that was paying all of our salaries at in those days, or not, or convert the building to an armory. So it
was, it wasn't a given that everything was going to work out. And your group must have been fairly tight-knit. It must have been pretty small compared to today. Roughly how big was the Department of Medicine?
There might have been 75, 100 people, maybe even not that many. The group practice now is, 1,000, 2,000, people who were in the group practice. So it was very small, very tight knit, and very collegial. And I think from the very beginning, and I think we still see that, although it's tough because, with all the basic researchers actually now in the Lazar building and the Sherman building, the clinicians, primarily, in the hospital having offices or in the clinical science wing of the medical school, we're not as tight-knit as, we had been, but I think the flavor of it being a very collegial place is, I think, still there.
Yeah, I came to town in 1979, and the Department of Obstetrics and Gynecology at UMass at that time was 3.5 physicians, FTEs. So much smaller than it is today.
Yeah.
So a smaller group, and you're in the midst of some transformations with regard to healthcare delivery, and with regard to organization of practice, and with regard to the treatment of disease. So there's during your career, a lot, almost everything that could change has changed.
Yeah. So managed care. We then went away from it, and then kind of like we're back to it. I think that the RVU way of assessing, how busy you are, was developed, during those years. And I think having to generate funds, as the faculty, whereas there wasn't so much pressure to do that initially, became, I think a necessity.
Sure. Now, when you were practicing, you were hired by UMass, you would be teaching medical students, you would be dealing with residents. Did you go to the other hospitals, or did you pretty much stay at university?
We primarily stayed at the University Hospital. I think until we merged with Memorial in 1998, it was like take two separate cultures and, put them together and expect things to, work, everybody be friendly and happy with each other. That took probably another decade.
Mm-hmm.
And I think that because St. Vincent's actually initially was going to be the university hospital for the medical school, and they hired, really high profile, outstanding people to be chairs of the departments. And then, however, the decision was made to all of a sudden not invite them to come over here as the chairs of the departments, and then all of a sudden build up another hospital that became the university hospital. So I think the relationship between St. Vincent's and the clinical enterprise and the medical school, I think, that didn't gel. I think there probably still could be some, sore feelings, about what had happened initially.
And in those days, the oldest hospital in Worcester was actually City Hospital, and in those days, it was quite active. It was there were residencies that had a good reputation, I understand.
Yes.
And gradually, I guess, there was a shift of the charitable care as well as the academics from City towards UMass. Would you say that's?
I mean, absolutely. And today, I mean, we're the place where, we're expected to take care of, the patients, who don't have insurance or, don't have a lot of money. It's interesting, when I first got here, there were 8 hospitals in Worcester. And then they were 3 because, it was like, let's start taking care of more patients as outpatients rather than inpatients. Mm-hmm. And then you were expected not to actually fill as many beds as you had in the past. So those other hospitals ended up closing, became other things, or, just disappeared. And then there was St. Vincent's, there was Memorial, and then there was, the medical center. Mm-hmm. And then when there was a merger, it became UMass, Memorial, and St. Vincent's, and that's where we are. That's where we are today.
Right. So during your career, basically, there has been a considerable shift of care from inpatient to outpatient.
Yes.
Back in the 70s, you might admit someone for asthma or chronic pulmonary disease, and they'd be in the hospital. How long would you say would be common?
Well, I mean, I think it could be up to 5 days. I mean, somebody who's really having a bad episode with their asthma, which is pretty infrequent now today, not necessarily so in the pediatric population, but in the adult population. Mm-hmm. And there was so much inflammation that to get a handle on that takes a while for that to quiet down. So, I mean, yeah, asthmatics could be here for, 5 days and not necessarily be on a ventilator in the ICU. It's actually a pretty uncommon event now to actually have status asthmaticus
sure.
on a ventilator in an ICU.
So this evolution occurred for, I believe, a couple of reasons. To give you one example from my practice, when I was a resident, if someone had to undergo a D&C, a very simple procedure to sample the lining of the uterus, we would admit them the day before. We would do the D&C, and we would send them home the next day. That would be 3 days. And today, the vast majority of that sampling is done in the office. If they do come to the hospital, they're usually in and out in a matter of a few hours. So part of it has to do with a different style, since the actual mechanics of doing the procedure and the actual physical recovery didn't change. But the other is that we have the ability to monitor patients at home. We have medications that we didn't have before that are more effective. So, particularly in pulmonary, I'm sure you've seen a tremendous amount of progress in that.
Yeah, absolutely. Absolutely. So one of the procedures that, I don't know if you remember John Zawacki. So John was a gastroenterologist, finished his training, and then actually came here in primary care. Mm-hmm. And then in the very beginning. So he was here like a couple of years before I came. John and I actually graduated Tufts Medical School together. So one of the things that John and I did was we ended up describing that you could have silent reflux as the cause of cough, and we used 24-hour esophageal pH monitoring to help us uncover that.
Mm-hmm.
And from an insurance standpoint, the insurers would not pay for 24-hour esophageal pH monitoring if you did it as an outpatient. You had to admit the patient to the hospital. And I remember having conversations with a variety of insurers saying it doesn't make any sense to be doing that, but okay, we'll admit the patient. So we used to admit the patient for the 24 hours to actually do that study. I mean, to do procedures, you know, mm-hmm. Sometimes you end up having to admit the patient.
And you bring up another important thing, which is that the relationship between those who provide care and those who pay for care has evolved. In the 60s and 70s, it was basically a matter of sending a bill and getting paid. And then starting in the late 70s and moving on, there has been increasingly experimentation going on with different ways of paying, of ways of reviewing what we do and getting pre-authorization, and attempts to control the cost of care and to try to minimize the amount of care given and streamline what care is given. And that has not always been a smooth transition.
Right.
So your group has grown, and how big is your group today, your pulmonary department?
So when I came, I was the only one, and then Mel Prater joined me about a year later. And so in January 1979, the Division of Pulmonary was one. In 1987, there was a special qualification for critical care, and so most pulmonologists actually took the exam to do that. Mm-hmm. And then critical care became a specialty, so then we became pulmonary critical care. We actually also incorporated allergy. Mm-hmm. I stepped down in February of 2005 because at that time I had the opportunity to become the editor-in-chief of the journal Chest. And when I stepped down, there were 13 people in the pulmonary allergy critical care medicine division. Mark Madison succeeded me, and to fill out the rest of my time, so the journal took about 50% of my time, we then started a department of critical care, a medical center department of critical care, and I became the chair of that. I still am. Mm-hmm. Then I don't know if you remember Walter Ettinger as our medical center president. Mm-hmm. So he came on around 2005, 2006. And he had been at Hopkins where they developed this EICU concept. We sort of changed the culture and changed the environment so that we were more of a happy family, no more silos of special interest for surgical critical care, anesthesia critical care, neuro critical care, pulmonary medicine critical care. And after 2 years of showing that we were actually going to be a cohesive team, we brought the EICU on board here. And because of that, critical care markedly expanded. And Mark Madison now has in the pulmonary critical care group 23 people.
Significant. Now, your career basically has, speaking of silos, there are a variety of things that you have been doing. So clearly you've been practicing pulmonary medicine, but you're also teaching residents and medical students. You're also doing research and publishing. So talk to me a little bit about how medical education has evolved during your career. What would you say the high points of change have been over your career?
I mean, I think that the major change as I see it really relates to evidence-based medicine. Guyette, it was in 1990 that he and his colleagues at Hamilton University, in Canada, actually started talking about it. Mm-hmm. That and the importance of clinical practice guidelines using evidence-based medicine, as the jumping off point for developing clinical practice guidelines. I think that teaching, and as you know, there was a great deal of pushback about evidence-based medicine's cookbook medicine, Betty Crocker medicine, it's bad for medical education. And it turns out that it isn't at all. Right. That variability is the enemy of the good. And so as much as you can standardize things, sure, quality will improve. And because we're so cost conscious today, if you actually focus on improving quality, you will actually standardize, you'll get there by standardizing things, and the cost of care will actually decrease. So that and really appreciating patient-focused care, which the Institute of Medicine, before they changed their name, preferred patient-centered care. Mm-hmm. And I think that, that no longer, had the patients be in a position where they would be, assuming a passive role. Mm-hmm. It's the 3 C's embodied within really patient-focused care are continuity, communication, and concordance, which is, finding the common ground. Mm-hmm. So those were, I think, major changes for the good in medical education, and I think, how we hopefully are practicing medicine. I mean, we're not perfect, but I think we're better than we were certainly when I was training.
Great. And the results today are so vastly better than the results, a generation or 2 generations ago. People are living longer, they're healthier. There's just a really remarkable improvement. So yes, we have a lot to be thankful for. Talk to me a little bit. Go ahead.
I'd be remiss if I didn't talk about safety issues.
Yes.
With crossing the, to err is human, that the Institute of Medicine, published in 2000, and then the year later, crossing the quality chasm.
Yep.
I think that, we are so far from perfect, and we clearly have to do better. It's interesting that the United States actually took the lead on uncovering that, the 8th leading cause of medicine when the, to err is human comes out, the medical errors, were the eighth leading cause of death in the United States. And then other countries, when they started studying this, actually found the same thing.
Right. Yeah. And to this day, it is something that is, requires continual attention. Talk to me about your research.
So the major research that I've done relates to cough, and really all aspects of it. And one of the most important stories, I think, in my academic career really relates to how it got kick-started. I remember as a fellow reading about the Arnold's nerve cough reflex. So Arnold was and is, I think, considered to be probably one of the finest pathologists, dissectors, that ever lived. And so he was practicing in the 1700s, and he uncovered what turns out to be the only branch of the vagus nerve that actually makes it to the surface of the body. So it's in the ear. And I remember reading that, you should always look in the ears because somebody may have a big cerumen plug that's irritating the auricular branch of the vagus nerve, which is Arnold's nerve. So I thought about that, and then I finished my fellowship because most of the time in my fellowship I spent in the dog lab. So now I'm at the Rhode Island Hospital in Brown University, and Mark Rosen is a third-year Brown medical student who Sid Brayman was the chief, and he hired me. So he was there a year before me. And he went up to Sid and said, I'm looking for 3 months to do a project. I have an elective. Do you have something for me to do? And he said, go see Richard. So he came to see me, and I said, why don't you go to the library, read everything that you can about cough, and put everything on a 3x5 card. And so at the end of the 3 months, he comes to my office. He's got 2 shoe boxes filled full of 3x5 cards. And what we did was we ended up categorizing everything. So here's something for an introduction. Here's the anatomy of the cough reflex, physiology, pathophysiology. There was really very little known about the diagnostic workup and what the causes were. We ended up, so I took the lead on this. It was a review article, and it got rejected by 10 journals. And we were distraught. I remember hearing that Al Sofer, who turned out to be a cardiologist, who was the CEO of the American College of Chest Physicians, and he was also the editor-in-chief of the journal that changed its name from Diseases of Chest to Chest. And I had heard that, he's a very friendly guy, and what did I have to lose? So I called the American College of Chest Physicians, and they immediately put me through to him. I told him that we had this review article, never had ever done it before, had been rejected by 12 journals, and did he have any advice for me? And is this something that Chest would publish? And he said, send it to me, and I'll get back to you. A week later, he calls me back. A week after he gets it, he calls me back. And he said, this is phenomenal. We don't actually publish reviews this large in Chest, but I am about to also become the editor-in-chief of the Archives of Internal Medicine. Give me 4 months, send me the paper, but do this, do that, do this, and I promise you I will publish it.
Wow.
So he published it, and that review gave Mark Rosen, Sid Brayman, and I ideas that we spent the next 20, 25 years, thinking about, things that weren't known that helped us, develop, studies and design studies based upon that. I became very friendly with Al Sofer, who now is still alive in his mid-90s. He actually launched my career. He was the editor-in-chief of Chest, and then I became the editor-in-chief of Chest. I tried, maybe I didn't succeed as much as he did, but I tried actually to mentor people, couldn't publish everything, and, tried to be helpful as much as I possibly could, like Al was to me.
Yeah. In your career, there's an element of sort of serendipity to everything here. You've had a number of zigs and zags that have had tremendous meaning to them, and a lot of personal contacts that have made such a difference, and interesting mentors. Just a remarkable career with a lot of interesting points. Now, we're having this conversation in July of 2020, and we're doing it over the internet. I'm not sitting in front of you like I have for many of our other interviews. And that is because we're in the midst of the COVID-19 pandemic. And many of us have been encouraged to stay home. Stores are only beginning to reopen. People are wearing masks on the street. And you're talking to me from your office. And so why don't you tell me how this pandemic has affected your practice and how you're handling it?
Yeah. So for me personally, because the people who are older and who may have some comorbid illnesses are at highest risk of actually doing poorly with this virus, I have not been at the front lines, at the bedside, taking care of COVID positive individuals in the ICU. So the younger people in the division, because I am, even though I'm not the chief, I am a member of the pulmonary critical care medicine division. Mm-hmm. I think that how everybody has pitched in speaks loudly about not only the collegial nature that, I think has always existed, in our institution, but I think crises like what we're going through brings out the best in everybody. And it's just been, just something wonderful to actually see, people doing things that they, didn't normally do. All of a sudden, people who weren't critical care, trained, at the bedside, helping out. Mm-hmm. I have been in the background, trying to help out running things. And so it's changed what I personally do compared to what I used to do with respect to critical care. However, with respect to taking care of patients in the ambulatory setting, I'm very involved in doing video primarily, but also telehealth visits. I think it's been remarkable how insurers, have decided that that's of value and, are actually paying for people to do telehealth visits. We are able to see patients face-to-face in clinic if the need does arise. I've not been in that situation yet, but I am prepared with, the masks and the face shields and the other PPE, personal protective equipment, to be able to do that if necessary, but that has not been necessary.
So this issue of video visits is an innovation that really had been discussed in the past, but just came right to the fore in response to the need to deliver care during this pandemic.
Yeah.
You're telling me it's working out okay.
Yeah, it is. And I think from a cough standpoint, since most of the new patients that I see, they could come from a long distance, but now, I can speak to them and see them at a long distance. Unless you've got noises coming out of the chest and you have a chronic cough, most of the time the physical examination is, as in most instances, it adds a little bit to the most important thing that we do, and that is taking a history. Mm-hmm. But being able to observe the general appearance of a patient, I think really does, if you spend time thinking about it and looking, tell you a lot of information. Mm-hmm. And so, I recently, as a new patient, saw this person who had a chronic cough. It'd been going on for decades, and she had a loose self-propagating cough, sounding like there was something down there. She did have a CAT scan that showed that she had bronchiectasis. And, I took a look at her nails and she had yellow nails. So she had the yellow nail syndrome that is associated with bronchiectasis. I was able to, get her to take her own vital signs, and I could see what her respiratory rate was. I could see if she's coughing and she's clearing her throat, and whether or not, she looked like she was chronically ill. And she actually looked pretty, she looked pretty good. So, I mean, there's a lot of information that, you can get by just looking at somebody.
And there's some information you're probably getting from those visits that you wouldn't get in an office visit, and that's you're doing a mini home visit. You're not only looking at the patient, but you're looking at what's behind it. And I suspect with your field particularly, that can provide some useful information.
Yes. No. It definitely does. So there was somebody else who I saw who actually, when I talked to her, had symptoms of hyperventilation syndrome, which can actually be the presentation of somebody who has asthma.
Mm-hmm.
And I asked her, if she could go to lie down somewhere. And so she ended up walking up 3 flights of stairs. I got a chance to look at the surroundings as she was going up 3 flights of stairs, but I had the opportunity to see that she was actually, her respiratory rate markedly increased. And then she sat down, and then I had her voluntarily hyperventilate, and she nearly passed out, and she ended up lying down. And then it was an animal on her bed, when she ended up lying down. So
yeah,
there's a lot of
got a ton of information there. Well, we're getting near the end of our interview here. I wonder if you have any sort of closing comments that you would like to make.
I think that for younger people, I think there are a number of things that I like with respect to giving advice. And so when I talk about patient-focused care, talk about the 3 C's, I think a Jewish proverb comes to mind, which is, so the days are like the pages of a book, and you have an opportunity to write your own story. And if you want the story, the chapter on whether or not you were a patient-focused care physician, you should think about that every day. And if you don't know what the patient-focused care thing is to do about a certain situation, you should ask yourself, what would I want the healthcare provider to do for my family in that particular situation? And often that would give you the answer to that particular question.
Great. That's a great note to end on.